Okay, going to talk about, of course, black cataracts, all the cataracts. The previous session also, I was talking to Ashwin Agarwal, and I was talking about the use of the flags, which is not only for the black cataracts, complex situations, but any situation for the matter. So today I'm going to talk about the polar expedition, the black cataracts using the flags, the catalysts. Okay, these are the financial interests. What are the keys to the refractive cataract surgery? Increase the refractive accuracy by doing a good biometry and addressing the astigmatism, decreasing the complications like corneal edema and the posterior capsule rupture, choose the best quality visual IOLs, and exceed the patient expectations, under promise and over deliver. Hard-bound cataracts is always a challenge to the phaco surgeons because the difficulty to crack the nucleus because of the leathery attachments, the thin posterior capsule, large nucleus, poor or no cortical cushion, increase in corneal edema and postoperative corneal decompensation, increase in PCR and nucleus drop as well. So you need to combine the technology with the technique. These are the machines which are available to everybody, and these are the brown cataract. It's actually like the piece of granite you can see here. Always look at the endothelium. Look at the endothelium. Make sure that the endothelium is very, very important before you deal with such cataracts by means of the phaco emulsification. If you do a manual phaco on this, probably you can have a corneal edema, or if you do a FEMTO phaco, you can have a crystal clear cornea. I'll tell you why for this. If you have a corneal edema, the corneal edema may clear in about a few weeks' time and maybe a few months' time. But the problem is the corneal edema is associated with a lot of inflammatory mediators which are released into the eye. And you can have something like a TAS, which is called fibrin reaction. And as high as about 25 to 30% of the patients can have associated cystoid macular edema in the retina, which may be a difficult problem to solve as well. So look at this manual phaco quick chop express, what we call as, and I'm using the phaco power of about 60% and a vacuum of about 450 on a Stellaris Venturi system, which is Stellaris PC system. And you can see here I'm doing a Rexis. Always the Rexis is done with the means of a trypan blue. This is a manual phaco wherein things go very easy. I do a trench. I need to do a trench here because very dense cataract. These cataracts are as thick as about 5 or 6 or even more than that, 6 millimeter. And see how I'm trying to bury the tip and chop. I'm using my chopper, the MOHAN RAJAN chopper. I don't have any financial interest. You can see how much time it takes for me to open up the posterior nuclear plate. Repeatedly, I have to do it in multiple quadrants. And every time I do that, bury that, I have to, expend some phaco energy as well. So use some phaco energy, and which means that every time you use a phaco energy, there is going to be a direct transmission to the corneal endothelium, and that is the problem. And this surgical time also takes a little longer time. You can see the EPT in this particular case, despite the fact that I'm using a cold phaco technology, about 24.3 seconds. So what is this catalyst? This FEMTO cataract, the manual phaco is like this, wherein you can, it's like Sachin Tendulkar, where FEMTO cataract is equivalent to Dhoni, I would say, because the Dhoni can play in all the formats, whether it is one day, T20 or the test. And that is where I think the FEMTO cataract can not only the complex situations, but also in softer cataracts, posterior polar cataracts, subluxatory cataracts, and everywhere, as long as the pupil does dilate well, you don't have to see. In hard cataracts, I do a vertical spacing of about 25, and grid space of about 250, horizontal spacing of about 10, segments for soft spacing of about 200 microns, and pulse energy anterior 8 and millijoules, and posterior about 10 millijoules. Rock hard cataracts, I reduce the vertical spacing to about 20, and grid space and all other things remain the same. So this to show you some of the this thing wherein you can see here, this is a fairly hard cataract. I'm using a FEMTO platform. I divided the cataract already. The Rexis has been done, and divided the cataract into six quadrants, or what we call as the sextants. I'm using just as simply as Sinski hook to open up the nucleus because it's already pre-cut there. That is the biggest advantage of the FEMTO. You can see it's already this pre-cut, and it's very, very simple. I just have to go in and bury. We use very less phaco power, and you can open up the nucleus thing, and then go ahead with the phaco emulsification without any problem, because everything is already done for you, and it just pops up into the phaco port without any problem. Now and then I inject viscode for all these hard cataracts into the anterior chamber to make sure my endothelium is cornea is very crystal clear. You can see another patient with a little more harder cataract than the previous one. Just to show you, I'm doing the main incision as well, the side port incision as well. And in 70% of the cases, I do the main incision unless the patient has got a very dense arcus senilis, and 60 to 70% my main incision works very well. You can see here, once I do, we have to be a little careful about hydrodissection because already the gas bubbles would have done some amount of pneumodissection as well. And you can see here, straight away, I'm doing the chopping. I'm burying the tip. You can see my tip is a little bit exposed. You can see that air bubbles or gas bubbles are coming up. The very fact that the gas bubbles are coming from the posterior to the anterior, it means that the cut has gone all the way to the posterior nuclear plate. I don't have to do any trenching, any this thing. I just have to just go in and bury, and then the pre-chopped area, I need to just have to do the lateral separation. You can see the gas bubbles again coming up, and it makes very, very life easy. Once you do that, because sometimes you can do octants, sometimes you can do sextants. I normally do sextants or octants, that is the 6 or 8 pieces. As I told you, now and then, viscode, I don't have any financial interest. And everything else, you can actually close your eyes and do the surgery, and without any problem at all. You can see this is a nucleus and more nucleus, very little cortex is there, and less was saying UPT is only 7 seconds in this particular case. Again, the rexis is free floating rexis, and in the catalyst, that is the biggest advantage. I stain the rexis, and then you can see here, these cataracts are very big cataracts, as big as about 8 to 10 millimeter, and occupying the entire capsular bag, as big as the thickness of the cataract, as thick as about 5 to 6 millimeter as well. And you can see here the chopping, otherwise the chopping, every time you have to bury in a manual phaco, you need to go and chop and use the phaco. This thing here, it's already chopped. You can see here, I'm just doing something like a lateral separation, which is very, very simple using the second instrument. You can use a chopper or a sharp chopper or a Sinski instrument, or even a blunt instrument will do the work very beautifully for that matter. You can see that the entire process is over. I'm just gradually increasing the size of the density of the cataract here to make it lacing. You can see again another patient with the preoperative corneal guttata. Corneal guttata, you can see the counts are less than almost 1,000, and very severe corneal guttata, very hard cataract as well. This is an ideal indication for a FEMTO flax because it makes life easy. This patient underwent a toric lens. You can see here, and the rexis is done already. And these corneal guttata, we don't want to use much phaco energy because already the cornea is compromised, and you don't want, especially in a hard cataract, you don't want to injure the corneal endothelium much more than anything. I'm using a Centurion mission in this particular case, and you can see here I'm doing using a chopper there and separating that. So already the chopping is done, the rexis is done, the minimal hydrodissection you have to do, and the pneumodissection is already done. You can see here the gas bubbles are coming out. The very fact that the gas bubbles are coming out shows that the chopping has gone all the way inside. You can see here I'm using a Sinski hook here just to separate that and making the life easy for that. You can see that postoperatively the cornea is fairly clear. Postoperative 2 hours after the surgery, the patient had good visual acuity of about 6/9 after the surgery, which in the case of a severe cornea guttata or a fuchs endothelial dystrophy, very, very difficult to get in a manual phaco as well. Day 1, you can see again the patient is having a fairly clear corneas. Again, this is a very, very hard cataract, almost a brown, black cataract. This they did the live surgery and the surgical strikes last year in 2020. And you can see here I'm using a Signature Pro mission. Whatever mission you're comfortable, whether it's a Venturi system or a Centurion or with the active fluidics, without active fluidics, whatever peristaltic or Venturi system. You can see here I'm doing the octants here. So you can see that the whole cataract is divided into 8 pieces there, and it makes life easy. And you can see that I'm trying to open up the posterior nuclear plate with very, very ease, very, very little lateral, or what you call the vector forces. They are the whole posterior nuclear plate already opens up, because the most important problem is this thing is the posterior nuclear plate, which is very leathery. And once the femto makes a cut there, and it makes it easy with your chopper to open up the posterior nuclear plate without any problem at all. And once you do that, you can see that you can now and then inject viscode into the anterior chamber, and the rest is history. And you can see it's so easy, and the whole thing pops up because all these things are already cut. Yeah, and it becomes very, very easy. You can see that these corneas, all these corneas are all hard cataracts, all very clear corneas on day 1, day 2, day 3. And you can see that clear corneas, crystal clear corneas, pristine wounds, no wound burns. And that shows that amount of phaco energy is very, very less in this. You can see the pristine wound in a very, very dense brown cataract, very, very difficult to see in this thing. Again, in a white cataract, just to show you, the white cataract, Argentina flag sign is a very major issue. But in white cataract, 100% foolproof method is the catalyst, the femto. You can see here again, I'm trying to, only thing is look for skip areas in a white cataract. Don't try to pull the rexes. Sometimes you can have skip areas in a white cataract. And that's why you have to make sure the complete. Once the rexus is complete there, and it is there, it's very easy for you to go ahead and do this thing. Many people say that the common misconception is that whether the white cataract, the femto will penetrate. You can see here, this is again on a patient with the white cataract. I'm doing a toric lens in this particular patient, and I'm doing the incision as well. And you can see this particular video. Yeah, you can see this. The rexus is already done. I'm just doing the side port and putting just to make sure that the skip area, I'm staining the capsule, because I want to make sure the skip areas are not, because in white cataract, there is a possibility of skip areas. Don't try to pull it. You can have tags on these things, which can lead later to the posterior capsule tear. And you can see here how the white cataracts also, the femto penetrates beautifully. The near total cataracts, the white cataracts, you can see that how it's beautifully opened up. It's of course not all that hard, but it's gone all the way down, and it makes life easy for you to do these cataracts. So the take-home message is flax in complex situations. White cataracts, hard brown cataracts, posterior polar cataracts. One of the biggest advantages is that you will be able, because you can have an offset of about 900 micron from the posterior capsule. The beautiful epinucleus cushion is there for you to do that. Subluxated cataracts, Fuchs endothelial dystrophy, all these are very, very important. Reduce surgical time, reduce effective phaco time, more precision, clearer corneas at day 1, reduce complications, safety, precision, bladeless, consistency, wow effect, good platform for marketing, differentiation practice from others. And that is a reason why I think flax is not only important. The previous session, I was talking to Ashwin Agarwal because he was asking a question. I was telling that it is not only good for, even for softer cataracts. These are we call as NHNT, or neither here not there cataracts. Very difficult to do a manual phaco because we end up in trouble. These patients come with a 6'9", 6'6" vision. And these patients, I think the best way to go about doing a safe surgery, because these patients' expectations are very high, is to do a flax for them. So the flax has got definitely better indications, expanded indications than what you can imagine. Thank you very much for the wonderful opportunity, Nivian.